All right, here we go. It is actually Thursday on week 4, but we had a play day, so we missed Tuesday's lecture, so I'm going to do that today on Thursday. Now, I'll point you toward a YouTube video where I've already done these things a million times. And I'll get back to you on that one. But this is Thursday's lecture, but it is Tuesday's material, so we stay in order. All right, so we're starting aneurysms today. And let's do a little review here of the aortic, which is where why would most of these occur in the aorta anyway? Higher pressure. This is where the high pressure is. This is the ascending aorta, aortic arch right up to here. Then this is the thoracic aorta. Goes through the aortic hiatus, through the diaphragm, becomes the abdominal aorta. Splits into the common iliacs, internal iliac, external iliac, common femoral artery. So general stuff about aneurysms. They are an abnormal dilation or outpouching of a blood vessel, almost always an artery, which is under much higher pressure than veins or the lymph system. Occasionally you can get an aneurysm in the heart wall following a really bad infection of the heart. Veins is pretty rare. We had a cadaver one time who actually had bilateral femoral vein aneurysms, which was very rare. They actually wheeled it down to the x-ray room and got x-rays of it. So it does happen. They may be congenital. You could be born with these things. Don't show this message again. Could be born with these things, or they could be acquired from, like I said, from an infection or an injury, a catheter procedure or something. You officially have an aneurysm when the artery has ballooned out by at least 50% compared to its normal size. Aneurysms may or may not be associated with a dissecting aneurysm, which is a special type of aneurysm we'll look at here toward the end. In general, it means the integrity of the vessel wall has been compromised, so most of your arteries you have quite strong arteries, but due to disease or penetrating injuries through catheters, sometimes they're not. And it means that the vessel wall has lost its integrity. Some diseases, other diseases that can, or just some diseases that can do this are Marfan's syndrome, Louis-Dietz, Ehlers-Danlos, neurofibromatosis. I actually took out about 15 slides on Marfan's syndrome, so that's on my YouTube channel. Hopefully somebody will talk about that. It's not really in my cardiovascular and pulmonary pathology realm, so I pulled those slides out. What's the danger of an aneurysm? Well, if the vessel is bulging out, that means the vessel wall is weak and damaged. You could actually rip the vessel wall, which could result in a severe hemorrhage because it's under such high pressure. And yeah, that's not good. You can go into hypovolemic shock and die from this really fast, actually. Another danger is inside. We'll talk about saccular aneurysms in particular, and even dissecting aneurysms. Inside the aneurysm, you don't get laminar blood flow, and the blood swirls, and it's really easy for arterial blood to clot or thrombus to form within these aneurysms. And in and of itself, the thrombus is not that big a deal, but if it breaks loose and becomes an embolism, that's a big deal. The risk factors here are the congenital diseases. I took this whole section out, but Marfan's, Ehlers-Danlos, Louis-Dietz, neurofibroma type 1 are the connective tissue diseases. You still should know the names of those if you don't already. And then vasculitis, vessel wall infections. is another risk factor. In fact, we should go down a little rabbit hole and talk about these blood vessel wall infections. Aneurysms that are sparked by a infection of the blood vessel wall, which is called, by the way, a vasculitis. Vasculitis is an inflammation of the blood vessel wall, usually from a bug. It could be autoimmune too, usually from Staph aureus. But if the infecting bug weakens the artery wall enough, it can bulge way out because of the pressure. And strangely enough, they call it a mycotic aneurysm. Mycotic aneurysm, which is a terrible term because mycotic refers to fungi. And this has nothing to do with the fungi. So why they call it that, I have no idea. But the term kind of stuck and they can't get rid of it. So a mycotic aneurysm is nothing but an aneurysm that was caused by a local, focal infection, usually with Staph aureus, but it could be other things as well. It's the cause of aneurysm in about 6% of those who end up in the hospital with an aneurysm. So it's rare, but not crazy rare like Marfan syndrome. And the weakened vessel, can lead to an outpouching, as I just said. This can cause both a true and a false aneurysm. And even if it causes a false aneurysm, it can lead to a dissecting aneurysm. So these bug aneurysms can be, or bug invasion, vasculitises can be trouble. And that'll make more sense, true and false. Will make more sense here in a minute. Where does the bug come from that causes these mycotic aneurysms? It can come from anywhere. It could come from a cut. You cut your hand doing something. You had a surgical, surgery to take a cyst, let's say, or cyst off, like a lipoma off your arm. You had a root canal. Dental procedures are notorious for letting bugs into the blood. So those are some of the places it could come from. What's the sequelae of a mycotic aneurysm? Well, just like any aneurysm, it's at risk for hemorrhaging. And so if the aneurysm pops, you're going to have high pressure blood squirting out of it, and you could go into hypovolemic shock and die from that. And then, just like any aneurysm, it encourages blood clot formation or arterial thrombus formation. And that thrombus can break loose and cause an embolism. Specifically, this type of situation, this is called a septic embolism. A septic embolism. That's an important word to make a note card of. And then the aneurysm sticking out like a sore thumb can compress other structures. Maybe it compresses the inferior vena cava, or maybe it compresses the renal artery or the renal vein, or the inferior mesenteric or superior mesenteric, so it can compress other structures and nerves as well. So it can be quite troublesome. Even if it doesn't pop, it can cause trouble. It can push into the vertebrae, and because of the pulsatile nature of an abdominal aortic aneurysm, it can erode, or a thoracic aneurysm for that matter, it can erode the vertebrae, and you can get scalloped looking vertebrae from this. Where's the favorite target? Where does it like to strike? Loves the abdominal aorta. That's the favorite place. I don't know if you've seen these in the cadaver lab. I haven't seen the cadavers. I haven't done those labs in a while. But we used to have several cadavers with abdominal aortic aneurysms. So they're very common. Thoracic aorta, they can occur, not as common as the abdominal aorta, at least in my experience. The abdominal visceral arteries, like the renal arteries, they can occur. These mycotic aneurysms we're talking about. Lower extremities, so the greater femoral, the femoral arteries, or intracranial, the circle of Willis. So there's some pretty bad places, right? Especially the circle of Willis. I mean, that's inside the noodle, up in the brain area, so you don't want one there. How about some risk factors? People who've had rheumatic fever are at risk. Now, why in the world would that be? Guess there's no one here to answer me. I'm used to having you guys answer me. Well, rheumatic fever, the bug that causes that damages the heart valves. It loves the heart valves. It loves the tunica intima of the heart. It scars it up. And if if scar tissue forms anywhere in the heart lining, that's a sticky place for bugs. Bugs can stick to that scar tissue and latch on and multiply. And that's the definition of an aneurysm. They invade the wall of a blood vessel or the heart, and they can cause a aneurysm that way. Artificial heart valves, atherosclerosis, inflammatory process. Also, if you have plaques, that also is sticky, and bugs can stick to that and really make that area weak. Old vessel wall injuries from previous vasculitis or catheter procedures are also. Anywhere there's scar tissue which messes up the laminar flow, bugs can stick and ultimately form an aneurysm. Here's a normal aorta. This is a contrast arteriogram. You can see the abdominal aorta quite nicely here. Check this one out. What do you think of that? It's crazy big, right? Yeah, just huge. So bug stuck in an area of atherosclerotic plaquing in this person, burrowed into the aorta and chewed it up to the point, made it weak, so slowly it started to bulge out and out and out and got bigger and bigger and bigger. These can get really, really big in some people if they slowly kind of expand. They can expand to huge sizes without ripping. If they quickly expand, they'll rip and the patient will die. It's just starting to do some scalloping here. Here's a CT scan of it. Okay. All right, out of the rabbit hole. Now back to aneurysms in general. They're really the same risk factors, or some of the same risk factors for mycotic aneurysms. Hypertension. Why would hypertension be a risk factor? Well, it increases the pressure of the blood vessel, and that's just going to help it stretch and balloon out even more. Having a history of bacteremia, which means you probably got bacteremia is bugs in the blood, and undoubtedly some of those bugs stuck to the vessel wall, caused an inflammation and damaged that wall, made it some scar tissue, so other bacteria could eventually latch onto that area and cause a mycotic aneurysm. Or just a regular, it doesn't even have to be a mycotic aneurysm. If the old vasculitis damaged the wall to the point it's weakened, it can just push right out without any bug invasion. I always ask this question, and you guys always get this wrong. Many get this wrong. It's kind of counterintuitive. But diabetes mellitus, it's bad for so many different things. But one thing it protects against is aneurysms. And so how in the world does that work? So all this extra sugar that is floating around in the bloodstream of even people who try to control their diabetes, they still have extra sugar floating around. And that sugar can get into the tunica media and basically weld the collagen together. Remember, we looked at the histology of the tunica media, how it's got those collagen filaments running kind of obliquely between the laminae. And it can weld them together, and they get really, really thick and stiff. And that process of welding together, of course, from biochemistry is non-enzymatic glycation, aka glycation or glycation-induced cross-linking. But it makes a really stiff and strong blood vessel wall, so you're not going to rip someone with diabetes. It's unusual for them to get an aneurysm because of that phenomenon. But let's not go by diabetes that fast. Of course, there are some dangerous sequelae with diabetes. That excessive cross-linking or non-enzymatic glycation, it makes the tunica media so thick and so strong that it can start to narrow the lumen size. And therefore, if you start narrowing the lumen, the heart's got to muscle up to pump through that, and you're going to have hypertension because of that. Hypertension will lead to atherosclerosis, which will lead to more hypertension. So you get that vicious circle. The hyperglycemia can also soak into nerves and damage those nerves so they start spontaneously discharging and causing pain. Very common scenario, diabetic neuropathy. You'll run into patients with that. Schwann cells are damaged, and the nerve short circuit and send pain signals when they shouldn't be. Diabetes versus capillaries is a little different story. Capillaries don't have a tunica media, so they're not going to thicken up. However, the chronic sugar levels, the exposure to sugar, actually shrinks the endothelial cells and of the capillaries and makes them really leaky, more permeable than normal. So you start to get a slow kind of a swelling going on, like a micro swelling, not enough to to be visible on the outside, but this micro swelling will cause tissue ischemia because it's hard to, we talked about this before, if you have a swelling in tissue, it's hard for nutrients to swim through that extra interstitial fluid to find the cell and service the cell. So you start getting cell death. It's especially common in the eyes. The nerves of the eyes and the nerves in the periphery die because of that mechanism, because of micro swelling. And yes, there are blood vessels within nerves. What is the treatment for an aneurysm? Well, you might have to cut it out and put a new piece of pipe in there. So surgery is, first of all, it may not be a surgical size yet. If it's over 50 millimeters or 5 centimeters, then it's surgical in size. I see these all the time in my patients, 20, 30, maybe 40 millimeters in size. And that's not that big of a deal, but they do have to be watched once they get over about 30 millimeters or 3 centimeters. You have to at least watch them once a month with some type of scan every 6 to 12 months. An MRI would be fine to watch them, or an ultrasound. Once they hit that 5 centimeter mark, they will recommend surgery, because the risk of it popping and killing you is just getting too great. If you have Marfan syndrome or some other connective tissue disease, then they will let it get to about 30 millimeters, and then they'll recommend surgery. Conservative management, you could treat it conservatively as long as it's not too big. You want to do things that decrease your blood pressure, and try to stop smoking, keep your diabetes would probably help it, but stop smoking, control the hypertension, control the cholesterol. And if it gets to the point where you have to have surgery, they can just basically cut out the diseased aorta and put a new tube in. It's made of Darcon. It's a prosthetic Darcon graft. And mortality rate for that type of surgery in a good hospital is about 2%. So 2 out of 100 will pass away from the surgery. All right, there are some different types of aneurysms we've kind of mentioned, but didn't talk about them much. So let's get into the true versus false versus dissecting aneurysms. So true aneurysms are just that. They're true aneurysms. They're a weakening of the blood vessel wall, and the blood vessel has expanded outward. There is no rip. There is no tear in the tunica intima. No tearing. It's just a weakening and stretching of a focal area, of an isolated area of the blood vessel. Okay, there's a couple subtypes of these. There's saccular and fusiform. So let's look at saccular first. There's a better picture of a saccular. So a saccular true aneurysm means that we had a focal weak spot in this blood vessel wall right here. Not a rip, there's no tear in there. It's just a weak spot. And with time, it ballooned bigger and bigger and bigger and bigger till you got this sac-like thing here. And that's called a saccular aneurysm. But the key is, in a saccular aneurysm, all of the tunics are still intact. There's no rip here. No rips, just a weakening and a focal, kind of isolated, one spot weakness, probably from an old infection that occurred right here. Weakened the area. Okay, so that's a saccular aneurysm. They can get really big, 5 to 20 centimeters. You can imagine one of the problems with these things, besides popping, of course, it could kill you if it pops. What about blood clot formation in here? Oh, this is a breeding ground for thrombus formation, right? The blood flow is going to be all crazy inside there, and it's not going to be very strong. And so this thing can throw arterial embolism one after another out of there. So that's the danger. And it just depends what's downstream from this, where this occurs. I mean, if this occurs in the ascending aorta, you could get a stroke, right? If you just follow the clot, follow the embolism downstream, it could get up into the left common carotid and go into the internal carotid artery and go up into the noodle, cause a stroke. Okay, so high chance of embolism from these things. Okay, so the other type, so we had a saccular true aneurysm. Now we have a fusiformal true aneurysm. Fusiformal true aneurysm. And this is just a weakening of the entire blood vessel wall in an isolated spot. Okay, so the whole thing is bulging way out. These can get really big as well. They can get really long as well. These are the most common type of true aneurysm. Not the sacculars, more rare. These are the type that I've always seen in the cadavers. These just general outpouchings. Okay, again, it's a true aneurysm, meaning there's no rupture, there's no rip in the tunica intima. It's just a general weakening in a big section, and it's all bulged way out. It can be very long segments, not uncommon for the entire abdominal aorta to be infected. Can reach up to 20 centimeters in size, which is big. Because that's just really big. I'm not sure if I took those slides out, but I had a really big one in here. I'm not sure if that's coming maybe next time. Anyway, they can involve the entire aortic arch, the ascending aorta, thoracic aorta, abdominal aorta. Okay, so those were true aneurysms, saccular and fusiformal. Now we have the false aneurysms. These are just the opposite. These involve almost all the time a rip in the tunica media. And it's not a weakening of the blood vessel wall, it's a flat out rip in the tunica intima, which allows blood to leak through the tunica intima and go into the tunica media and maybe right through the tunica adventitia and right out into the body. Okay, aka pseudoaneurysm. Here's a cartoon. You can see all the tunics have ripped in this one. Now an infection could still cause this. You could get a very aggressive infection that could eat a hole, not just weaken the vessel wall, but eat a hole right in it. Or it could be a catheter injury from an angioplasty, or maybe you got stabbed in a knife fight, or you got in a car accident and a rib poked right through your blood vessel. So these are flat out holes in the blood vessel wall. These are very dangerous. These are the ones that are more likely to rupture and hemorrhage. And that can happen very fast. Emergency surgery is often indicated. And if it does happen to heal up, it's going to leave a massive scar. And that makes you at risk for a future mycotic aneurysm, because bugs can stick to that injury site after it heals. The luminal blood can escape, or does escape, through the tear in the tunica media. Everything we said already. It could rip completely through and cause a hemorrhage. You could die of hypovolemic shock. Yep. Sometimes that connective tissue layer around a vessel, remember on top of the tunica adventitia, there is a tough connective tissue. Sometimes that's the only thing keeping the blood from leaking out. It can also progress. These are the type that can progress into something called a dissecting aneurysm. And we're going to talk about those and the different types of those things. Those are killers. But a false aneurysm can lead to a dissecting aneurysm. And we'll get to that one in a minute. Back to just in general, abdominal aneurysms of the abdominal aorta can be palpable. We're going to teach you how to do that. So if you palpate one, you should always refer for an ultrasound, or at least send the patient out to a vascular surgeon. Ultrasound's about 97% sensitive, so it's a very low false positive rate for picking these out. Snout, good for ruling out. And here's exactly where you look for abdominal aortic aneurysm. You only do this in one spot. You don't go searching around, because if it's palpable, it's going to be right above the belly button. Xiphoid would be up here. You're going to push in like that. We'll show you how to do that in the lab. Dissecting aneurysms, called, sometimes they're aortic dissections or dissecting aneurysms, dissecting aortic aneurysms. They almost always occur in the aorta, where the high pressures are. Unfortunately, there's two other places that they like to occur: the vertebral artery and the internal carotid artery. So we'll talk about that when the time comes. But these are usually just a complication of a false aneurysm. Remember, false aneurysm, you get a rip in the tunica intima, and the blood can push through. And it occurs when the blood pushes through the tunica intima, gets into the tunica media, but then hits that external elastic laminae. Remember that thing? Did I put a picture in here? Yes, I did. So the blood will rip right through the tunica. Here's the first layer, tunica intima. Blood rips through there. It rips through the internal elastic laminae. It rips through the smooth muscle, but it hits the external elastic laminae, which is pretty tough, and it discourages blood from ripping all the way out. So instead, the blood rips right through the tunica media longitudinally, right down like that. And I'll show you better pictures here in a second. But that's a dissecting aneurysm. Occurs when blood gets into the tunica media and stops there and continues longitudinally down the aorta. And it can go for a long, long ways. About 95% of the time, it starts as a tear, starts as a false aneurysm. We'll talk about next time, we'll talk about how it can start from the vasovassorum. Remember the blood vessels within the blood vessels? Sometimes you can get an aneurysm in one of those little blood vessels, and blood can just start squirting out in the middle of your tunica media. But most of the time, it's going to be from a false aneurysm. And everything we said already. Right, looked at that. Here's a nice view of it. So here we had, maybe it was an old infection, maybe it was a catheter procedure, but the blood ripped through tunica intima, got into most of the tunica media, hit that external elastic laminae, or hit the tunica adventitia, and couldn't go through it. Instead, it finds it easier just to rip right down the tunica media. And that is a dissecting aneurysm. And what do you think is going to happen to this? I can hear you guys trying to figure that one out. What's going to happen is the pressure builds up and builds up and builds up in here. It's going to rip right back in. That's called double barreling. But in the meantime, while you're waiting for it to rip back in, which could take days or weeks or months, what's going to happen to a lot of this blood in here? It's going to clot. So you're going to have a whole bunch of clots that form. And you can call these clots. You should call them hematoma, though. But this isn't thrombus. Thrombus occurs inside the blood vessel. But you're going to have these bombs ready to go. And when double barreling occurs, you're going to unleash all those blood clots into the bloodstream. So not good, no bueno. Right, another view of the false lumen. So this is the true lumen. So we've actually created a new lumen, right? So there's a new lumen. On CT scan, which is a slice like an axial CT, it looks like you have two lumens. So the fake one here, this is called the false lumen. But this can get really big, and it can actually push into the true lumen and narrow this true lumen. So that's, it can cause stenosis. Right? Here's a CT, axial CT of someone with a dissecting aneurysm, and sure enough, you can see the aorta, and you can see the false lumen, and there's the tunica intima, and half of the tunica media is right there. So, yep. And as this gets bigger and bigger and bigger, it pushes more and more into the true lumen, and now you got yourself a beaver dam of the true lumen. So that causes stenosis, which is going to cause hypertension upstream and hypotension downstream, ischemia downstream. And you can just think of all the problems that can have. So clinical signs of a false, of a dissecting aneurysm with a false lumen that has caused stenosis. What are the clinical findings of that beaver dam? Well, downstream pulses will be decreased. The upstream pulses may be increased. You may have ischemic changes downstream. Maybe you're getting skin changes around the gator areas, around the ankles. Maybe you're having claudication. They go for a walk and they can't walk anymore because their legs start hurting and run out of power because they're not getting enough blood. You bring them into the clinic, do Berger's test on them, and Berger's test is positive. We talked about that. You do the ankle brachioindex test, it's positive. So let's see. They might have hypertension too if this occurs. If the beaver dam occurs downstream from the renal arteries, you might, or if it occurs just upstream from the renal arteries, it's going to shut off blood flow to both kidneys. So you could have hypertension as well, depending on where it occurs. And then we have already said that blood clots can happen very easily inside the false lumen. So the false lumen is said to be very highly thrombogenic, which means it can form blood clots. And it's very dangerous when the double barrel occurs, as we said. Double barreling, as we said, occurs when the false lumen rips its way back into the true lumen, which usually happens with the passage of time. And now we have kind of two routes for the blood to go, which is not that big a deal. But the danger occurs when all those blood clots are released, like in this cartoon. So all these blood clots were building up, and it finally broke back in. False lumen now communicates with the true lumen, and we just released all these bombs which are going downstream, and who knows where they're going to be. I would ask you in class, could this cause a stroke right here? No way, right? You'd have to go up in one of these to get up into the internal carotid artery, so no way. But they could go into the celiac trunk, remember that one? Superior mesenteric artery, inferior mesenteric artery, renal artery, could go down into the legs, who knows? But these are definitely going to cause trouble somewhere. They're going to cause some tissue death somewhere. Right, there's just another picture of the thrombus breaking loose. I think that's about it. We hit our 50 slides. Almost done. Favorite place to occur? Well, dissections occur where the pressure is the highest. So it's usually between the root of the aorta. That's where the aorta connects to the heart, and then somewhere in the proximal part of the thoracic aorta. So that's the most common place for these to occur. All right, short and sweet. So So I will let you know how we're going to make up the next lecture. See you later.